Hello, and welcome to the 2022 Living with Parkinson'S Symposium. I'm Judy Friedman, the Vice President and Executive Director of the Maryland Association for Parkinson's Support, or MAPS for short. We had planned and hoped that this year we'd be able to join each other in person, but COVID had other plans, and since it's better to be safe than sorry, we are Zooming once again. Fingers crossed for 2023. For this year, I want to thank our incredible committee for helping to make this day possible. Nikki Barr, Karen Amoyle, Patty Wessels, Jesse Monahan, Rita Davis, Christy Carpenter, Hillary Raison, and Bobby Levine. Thank you. I also want to do a special shout out to our sponsors and partners, Synovian, Accorda Therapeutics, Amneal, Kiowa Kieran, Barry Steinfelder, the Parkinson's Foundation, MedStar Good Samaritan Hospital, and the Edward A. Meyerberg Center. And a very special thank you to the physicians and presenters who are taking time out of their weekend to talk with us today. Dr. Gregory Pontone, Dr. Stephen Rich, Dr. Yasser Torres-Yagi, Dr. Carlene Schwimmer, Dr. Ashley Paul, Patty Wessels, and some of her absolutely incredible rocking rocksteady boxers, Trisha Ubaki and Harold Hardinger. Thank you. This year, the symposium is missing one very special and incredible person. As many of you know, Rona Rosenbaum, the founder and chair of MAPS, died in March. She is very much missed, but she has unquestionably left her mark on this day. MAPS and the symposium were her babies. She decided on today's theme, and she spoke with many of the presenters. She very much wanted today to be about you, the people who every single day are living and dealing with the many challenges of Parkinson's. So Rona, here's to you. One more thing, don't forget that our silent auction starts today, and the information on how to access the auction is on our website, www.marylandparkinsonsupport.org, and it will also appear on your screen several times during the afternoon. In fact, this whole symposium will be available to view on the MAPS website within several days. So again, welcome and enjoy the afternoon, and thank you so much for coming.
Welcome to our Living with Parkinson's Symposium. I want to first remind everyone of a few tech tips to enjoy the best experience during today's events. Please make sure you have printed or written down the following webpage, www.meyerberg.org/LWP. You can also find this link in the Zoom chat. At the end of each session, the host will end the Zoom meeting and participants will need to return to this webpage to access the next session. It's very important that you have this link readily available during today's events. For the duration of the event, all participants' microphones will be muted and videos turned off. During the Q&A, you will enter your questions in the chat. If you'd like to submit questions after the event, please send an email to info@marylandparkinsonsupport.org and include the name of the speaker, your name, contact information, and your question. Make sure the volume on your device is turned all the way up. If your session freezes, don't panic. Simply leave the session, return to meyerberg.org/LWP, and click Join Session. For best streaming quality, watch the event from a location closest to your Wi-Fi router. If you run into any issues during today's event, please call our tech support hotline at 888-627-7880. And finally, a quick reminder that all of today's events will be recorded. The links to the recordings will be emailed to participants after the event. And now, it's time to get started with our keynote speaker. Our keynote speaker is Dr. Greg Pontone, Director of Parkinson's Disease Neuropsychiatry Clinic at the Johns Hopkins University School of Medicine, which focuses on diagnosing and treating the neuropsychiatric aspects of Parkinson's disease and related disorders. His research focuses on the interaction between neuropsychiatric symptoms such as cognitive impairment, anxiety, depression, and motor impairment in Parkinson's disease. Please welcome Dr. Greg Pontone.
Hello, I'm Greg Pontone, and today to kick off this year's seminar for the Maryland Association for Parkinson's Support, I want to talk about a wellness prescription for Parkinson's disease. And so to start, I think it's important to define what wellness is and describe how it might apply to Parkinson's. Then we want to describe the risks of poorly managed Parkinson's and what you can do to overcome barriers and avoid bad outcomes. And then finally, discuss how you can achieve wellness by changing your behavior and adopting healthy mental attitudes. So, defining wellness in the context of Parkinson's disease. Well, first of all, what is wellness? The World Health Organization defines health as a state of optimal well-being, not just the absence of disease symptoms and infirmity. And wellness is the active pursuit of the activities, the lifestyles, and the choices that you make that will lead to this state of health. And so when you think of wellness, it's an active pursuit. The traditional medical model in the West is this idea that you treat the symptoms and signs of a disease to avoid disability. But for the most part, our treatments and interventions stop once the symptom has been managed. And wellness really is about extending this paradigm beyond just the absence of symptoms to where you're growing and achieving the highest quality of life you can beyond the disease symptoms. And so let's talk about some of the things that have to be overcome in order to achieve wellness in Parkinson's. Well, everybody who has Parkinson's is aware of the movement symptoms. And in addition, there are what we call the non-movement or non-motor symptoms of Parkinson's. And the common movement symptoms are bradykinesia, which is a slowing of physical movement or a reduction in the size of movement, tremor for many people, an increase in tone that's experienced as rigidity or stiffness. Some people have dyskinesia, which are fast wiggling movements of their trunk or upper or lower extremities. Sometimes people will have sustained contractions of parts of their body. This is called dystonia. And then all of these symptoms together can affect your walking, or what we call gait, and your ability to maintain your balance, especially when challenged. Non-motor symptoms are equally important in terms of their impact on your quality of health, and they include things like anxiety and depression. Some people develop cognitive impairment. Then your autonomic nervous system has been affected by the Parkinson's, and it'll produce in the gut constipation, sometimes stomach cramping or other problems. Changes in blood pressure, especially going from sitting to standing. You might feel faint. That's what we call orthostatic hypotension. And all of these, again, are sort of unified by the idea that your autonomic nervous system is affected by Parkinson's. Parkinson's can cause pain in many different ways. Some people experience hallucinations and maybe falling asleep or staying asleep, or some people act out their dreams. And so there is quite a burden that the disease might bring, but there's also an uncertainty because you don't know exactly what it'll bring and when. Now, our healthcare system also presents a little bit of a challenge because the current model focuses on medications and devices to relieve the motor symptoms of Parkinson's. And to some extent, they've sort of neglected a little bit the mental health aspects of Parkinson's. They're provider driven, meaning that your doctors or nurse practitioners are saying, hey, take this medication. Or in the case of devices like deep brain stimulation or other interventions, we're saying we're going to do this to you to try to relieve this symptom. Where the sort of wellness model is more about what you as the person with Parkinson's can do to overcome these symptoms. And these have unfortunately been de-emphasized or frankly neglected in our current healthcare model. In fact, oftentimes these wellness type interventions, things that you can do, aren't even reimbursed. And that's a problem. Other barriers to achieving health in Parkinson's are the scarcity of resources. So finding a movement disorder specialist can be challenging. Finding a mental health specialist can be even more challenging. There's disparities in healthcare access by the type of insurance you have, whether you can pay out of pocket or augment the insurance with personal pay. Geography. So urban centers are more likely to have specialty care centers, whereas more rural locations may not. Often there's a lack of awareness about mental health. And so that can be a barrier because you're just not aware that this comes with the territory of Parkinson's disease. And then another sort of insidious barrier is what we call stigma. And this is especially true regarding any mental health issues in Parkinson's or elsewhere. And so what do we mean by stigma and this sort of dual stigma of mental illness? Well, stigma are sort of a set of assumptions or judgments that are made about people who have conditions, especially when they're visible signs like a tremor or dyskinesia. And this often leads to negative stereotypes or a devaluation of people by society, that they're less capable, or that something's wrong with them, or they're weird. And so overcoming the stigma on both sides, on the side of the individual so that they're not inhibited or avoiding going out into the world, but also by the society to be more accepting of individuals who have challenges is going to be an important thing to achieve wellness. And one of the things that I think can help, especially with the mental health issues in Parkinson's or anywhere, is this idea that in the same way that the movement symptoms are caused by changes to the substantia nigra and the dopamine levels, mental health symptoms like depression, anxiety, and hallucinations are caused by changes in the level of neurotransmitters, things like serotonin, norepinephrine, and acetylcholine. And so when you start to think of mental and physical symptoms as connected to brain chemicals, you can see that there's no reason to stigmatize one set of symptoms over another. At least that would be my hope. And so sometimes education about where these symptoms come from and the cause can help with some of the stigma and the barriers. Now, let's talk about some of the other challenges in Parkinson's disease, and then we'll talk about solutions. So uncertainty about the future is a big issue for most people with Parkinson's disease or any chronic disease. You don't know exactly what the future will bring. You know, you had one set of expectations when you were healthy, and now you have a disease that has variable symptoms. And so as you look at this figure, the horizontal line sort of shows you things that can happen before the diagnosis, sort of vague symptoms that sort of herald the onset of this movement disorder at time zero. That's when you first start to notice your movements change. And even the movements can be variable and uncertain. So, everybody will have some degree of bradykinesia, the slowing of movement, but up to a third of people with Parkinson's won't have much tremor at all. People will develop dyskinesias and fluctuations in the response to the medications, but it's unclear when. They might get these at 5 years into the disease, they might get at 10, and lucky people might take 15 to 20 years before they start getting dyskinesia or fluctuations. Some people will have urinary symptoms early on or mid-disease and changes in their blood pressure, and other people will be spared that. Some people will experience cognitive change. In fact, some people may even experience severe cognitive change in dementia. About half of people will have hallucinations and delusions. but that also means half of people will be spared these symptoms. And so really that uncertainty generates a lot of stress and anxiety in people. And so even the treatment can introduce some uncertainty. So for the you less confident about your ability
The
to
other
function.
person has call captions enabled. Please start speaking.
And so dyskinesias are another symptom that can erode your confidence. And these are sort of the wiggly wobbly movements, the fast movements that you'll see people do. They usually occur as the dose peaks in your system, although they can happen sometimes when you're wearing off, but usually at the top concentration of the dopamine medications in your system, you'll start to wiggle around, and it might not feel bad. And actually most people report that they move pretty well, but it can make you self-conscious, and it can be a little unpredictable because you don't know if it's going to last a few minutes or a few hours, or if you're going to start sweating because of the movement. And so again, all of these things together make your walking, or what we call gait, and balance a little more treacherous. And so people start to have falls, and then they can even develop a fear of falling, or they can freeze. They'll be walking along, and for instance, they want to cross a threshold and they'll freeze and stop moving, or they're in a crowded room and they find that they hesitate to take a step. And this, again, all sort of goes together to sort of make you stressed out and less confident about your ability to function and to live well. And these are just the movement symptoms. So, the other important thing that I think we found out is that mental health conditions can also contribute to this, this sort of reluctance to be active. And so the Parkinson's Outcome Project by the Parkinson's Foundation is one of the largest ongoing studies of Parkinson's disease. And it found that depression, so a non-movement symptom, affects quality of life about twice as much as the motor impairments that we just mentioned. And so that's another important thing to address to have optimal health. Now, we mentioned hallucinations and delusions, which are sort of false beliefs. And then sometimes these beliefs can make people have behavioral problems. They might act out, or if they're paranoid, they might be irritable or things like this. And although not everybody will have these, this is another barrier that we have to be aware of, because it turns out that more so than physical disability, having behavioral changes and hallucinations and delusions are a greater risk for nursing home placement. And I know for many people, loss of their independence or being placed outside of the home is a big fear. And so it turns out that these mental health issues can actually be a bigger risk for being placed outside of your home than the disability. In fact, in my experience, most of the people that I work with in Parkinson's, even if they're limited and need to use a wheelchair or a walker for long distances, they don't end up in a nursing home for that. It's when their behavior changes that they go. And the good news is all of this is treatable. Now, the other big risk is that when you start to have trouble with movement, and you start to have depression, and you start to be less confident, you're more likely to be socially isolated and lonely. And so social isolation is an objective thing. It's something we can point to and say, hey, look, you have a lack of interaction with other people, whether that's family members, friends, or the wider community. You're sort of shut in by yourself. And then the more that you're isolated, the more at risk to become lonely you are. Lonely, though, is a little more subjective. So lonely is sort of a negative feeling that's associated with a perceived lack of a wider social network or the absence of a specific desired companion. And so these two things sort of go hand in hand, and they're interrelated, but different. Okay. And I think they're important to talk about because I think they're undervalued. People say, well, okay, great. Yeah, I'm a little isolated. And, especially during the pandemic, I think we became more aware of these two concepts. But let me show you how important they are, because I don't want you to think these are fluffy, light concepts. It turns out, and this is in Parkinson's, but also in people who don't have Parkinson's, that social isolation significantly increases your risk of premature death. And so it rivals the risks of smoking, being overweight, and physical inactivity in terms of your risk of a premature death. Social isolation is also associated with a greater risk of dementia. And this is both in Parkinson's and in people who don't have Parkinson's. And then inadequate social relationships are also associated with a 30% increase risk of heart disease and stroke. So this is with or without Parkinson's. So none of us, we're social animals. None of us does well without social interaction. So there's something about being around other people, interacting with people, that's nourishing to us. So I wanted to make this point very strongly because I think people undervalue the importance of being part of the wider community. Now, I've sort of talked about all of the things that sort of burden you because of Parkinson's and all the barriers to living well and having the best quality of life you can have. But now let's talk about what can you do, not what the doctor's going to prescribe you, not what the surgeon's going to do to you, but what you can do to live well and experience a higher quality of life. And so I like to think of things very simply. And so these are what I call the big three: exercise, diet, and sleep. And I think this is a fun little advertisement by the National Sleep Foundation. They basically say sleep as important as diet and exercise, only easier, right? All you have to do is lay your head down. And it turns out that, at least in my opinion, and I think the scientific literature supports this, that sleep is probably maybe more important than either of exercise or diet alone. And so don't undervalue sleep. And so developing good habits around sleep is really important. And if you look there at the bottom of this slide, there's actually a website that gives you a bunch of good tips on how to sleep as well as you possibly can. Now, people often ask, is there a Parkinson's diet? And unfortunately, there isn't a Parkinson's specific diet yet. There's research that's ongoing. But what I would say is that one of the healthiest and scientifically backed diets any of us can follow is the Mediterranean diet. And to take that one step further, if you combine the Mediterranean diet with a diet that's designed to control cardiovascular risk factors, right, to improve heart health, called the DASH diet. If you put the DASH diet with the Mediterranean diet, we call it the MIND diet. And it's been shown to sort of reduce your risk of dementia as well. And so this is the one I follow. This is the one that I recommend to the people I work with who have Parkinson's or frankly, any other neurological condition. And this little diagram that you can download from the internet pretty much tells you the basics of what you have to do. It's a fairly simple plan and easy to follow, and it's got great science to back it in terms of helping deliver good health outcomes. Now let's talk a little bit about exercise. So remember that pyramid had exercise, diet, and sleep. Exercise is unequivocally good for your Parkinson's movement symptoms. People move better, they tend to live longer, so it's great for your physical health. But it turns out that exercise is probably also one of the most important things you can do for your mental health. And it turns out that in both animal models and human models of Parkinson's disease, exercise improves cognition. And they looked at 3 basic types of exercise: cardiovascular or aerobic exercise, things like walking, riding a bike, resistance training, so lifting weights or body weight exercises that tax the muscle, and then flexibility and motility, so moving through a range of movement, even without resistance. And just to show you that there is a lot of work being done on this, there are at least 18 high quality articles that show that cardiovascular aerobic exercise, most commonly in the studies, it was riding a stationary bike or walking on a treadmill, improved attention, processing speed, reaction time, executive function, which is your ability to organize, sequence, and plan, and language. And so it turns out that for mental functioning, physical exercise is probably one of the best things you can do. And oh, by the way, it also reduced the severity of depression. And so it's as good as any medicine for these symptoms. They did also look at weight training, or what we call resistance training. There were fewer studies, but again, they clearly showed that it was good for specifically cognition, things like executive function and attention. And they showed it improved balance and gait in Parkinson's disease. So again, many, many reasons to do this exercise. People often ask me, well, what about stretching and mobility, flexibility, yoga? These are good too. They just haven't been studied as extensively as these other types of exercise. And so more research is needed to know exactly what type of benefit they'll deliver. But certainly, I think doing a combination of all 3 types of exercise is probably your best strategy. And do it in a group, because then that adds that social element that we know is important. And so that brings me to the next point. So we're talking about, sleeping right, eating right, and exercising, but staying socially connected. Remember, I just showed you all this evidence that it increases your risk of a premature death if you're not connected and if you're isolated. And so, I think more and more your healthcare team should prescribe community activities that help you establish both social support, but also connections that are likely to lead to you being invited to other activities. And so that you'll be less isolated. And if you're less isolated, you're less likely to be lonely as well. And so that leaves just the sort of mental strategies, or what we call positive psychology. So how do I approach this, right? Because there's a lot of things that are going to challenge me in Parkinson's disease. So what can I do to keep the right mindset? And so let me just throw out some concepts here. And there's actually books and articles on this that you can look up on the internet, but I'll mention them just so that you're aware. The first is self-agency. And there's this idea, it's this idea that you have the ability to achieve your goals, right? That you can have help from others, but you alone can pursue these goals. You're competent and capable. And then psychological flexibility. Like I said, you're going to be challenged and you're going to have curveballs thrown at you. And so this is the ability to redirect your mental resources in accordance with situational demands. And so, rather than focusing on the negatives or a bad outcome, to sort of shift and say, well, okay, I have lemons, let's make lemonade, turning a situation that already has a bad outcome into what can I salvage? Coping is an even more sort of higher order complex strategy or efforts that manage both the internal and external demands of a stressful situation. So, you might be feeling anxious and you might also have a physical challenge to overcome. And coping is finding a way to manage both, controlling your anxiety so that you can exert maximal effort on whatever the task at hand is. And then finally, resilience, because the truth is, with or without Parkinson's, we're all going to be challenged and have some negative experiences, but resilience is our ability to bounce back and try again and try again and try again. And really, success is just a successive number of trying agains, right? In anything we do. And so really the sort of practical strategies to improve your day-to-day functioning, the one I think that has been undervalued and I really want to make a point of emphasizing today is stay connected. Okay. Social isolation and loneliness are big health risk factors. Okay. Stay engaged. It turns out you don't necessarily have to take classes or do anything like the New York Times crossword puzzle. You just need to participate in structured, challenging activities, social outings. These are exercise for the mind. Okay, that's good enough. If you like the other things, you can do those as well. They're even better. Sleep well. Poor sleep is both a risk factor for and a symptom of depression and anxiety. And decreased sleep can change your ability to problem solve and decreases your processing speed. So remember that pyramid and make sure that you're sleeping well, eating as well as you can, and exercising. And I think if you follow all these things, that'll lead to wellness in Parkinson's. So we'll take questions a little later in the seminar.
Okay, at this point, Dr. Pontone will answer any questions you might have. Feel free to put your questions in the chat. We do have about 60 people on today, so might be a little smoother if questions go in the chat for now. So to kick things off, one of the first questions that came in: when a caregiver notices behavior problems, do we take the client to neurologist or psychologist?
Hello, good afternoon. So great question. I think for most problems, it's always good to start with the treating neurologist. Many of the movement disorder neurologists, certainly that we have here in this region, are very capable of at least the initial sort of assessment of the behavioral problem. And sometimes, if it's related directly to the Parkinson's care, let's say, for instance, it's related to the level of the dopamine medications, they can make adjustments that address the problem directly. Now, once that problem has been identified, if there isn't a immediate solution from the neurologist, then it's time to sort of start collaborating with a mental health care provider, whether that's a therapist, a psychologist, a psychiatrist, depends on the problem. But I always say start with the treating neurologist because they're well versed in many of the common problems that we see here.
Thank you. And the next question we have: who manages medications?
Well, that's, I've seen different strategies work. For many people, because Parkinson's is the sort of focus, it's a chronic long-term condition. Many times the movement disorder neurologist acts as sort of the gatekeeper, coordinating medications related to the disease or any of the disease sequelae. In other cases, though, if there's a very involved primary care physician, that physician will act as the sort of coordinator between all the specialties involved in care. What I tell people is, if you have someone that you have a good rapport with and you have a good working relationship, that's probably the individual to try to get to be the coordinator. And again, it's really a conversation between you and the provider. But I do think having one sort of central physician who helps oversee all the consultations is going to be really important. So that's a great point.
Very good. Another question posted has to do with the sleep website. So at some point, we'd love to maybe put that in the chat if we could get that website again. And then along with that, the question about how much sleep is actually recommended.
Yeah, so this is probably the single most asked question when we get talks on sleep, is how much is the right amount. And what I can tell you is that the minimum is about 6.5. So what I can say is that in studies in the population at large, not just Parkinson's, that anything less than 6 has health implications, adverse health outcomes associated with it. So I always tell people, aim to get 6 or more. Now, an individual may need more. So there's some people who are just genetically predisposed to need a higher amount of sleep. And then there are a few people who might need 6 or less, but I have to tell you, they are a minority, a single-digit minority of people. So for the population at large, I always tell people aim to get 6 continuous restful hours. Good
to know. I certainly know some people who claim that they can live off of 4 hours of sleep, and maybe those are just the ones that fall into, it's just in their genes somewhere.
Yep.
Should we seek a fall training? Fall prevention?
Yeah, so a lot of the physical therapy programs, and even to some extent, some of the big and loud programs teach you how to mitigate the results of a fall, and more importantly, I think fall prevention is the way to go. You're never going to completely avoid falls and Parkinson's, but I think anything you can do that helps you, sort of limit the risk of falls is going to be useful.
Thank you. Let's see. Given your comments about the importance of adequate sleep, can you maybe make some recommendations on how to achieve quality sleep? This person actually has difficulty staying asleep for more than 4 or 5 hours. So kind of going back to the sleep topic again.
Yeah, no, and you know what? It is so important that I'm glad to see it's generating interest. And I think probably the first thing I should say is that Parkinson's disease causes a lot of sleep difficulty. So even people who previously not had any trouble sleeping may now have trouble sleeping. And that's, something that might need you to work with your doctors to fix. But in terms of what you can do, the first thing we tell people is try to have a pretty consistent bedtime and a pretty consistent wake time each day, right? So that let's say you like to go to bed at 11, try to more or less be in bed by 11 every night, and then have a routine. So usually if you have something you do that's relaxing and de-stimulating you, okay, so you don't want to be doing anything rowdy or that gets you emotionally charged before sleep. Believe it or not, the light from phones and tablets and computer screens can sometimes also trigger networks in the brain that keep you alert and active. So try to limit screen time just before bed. We usually tell people that if they bathe at night, a good strategy is to take a sort of warm shower or bath and then allow yourself to cool quickly. So it turns out that the rate at which your body cools is another factor that can be a initiator for sleep. So there's all sorts of little things you can do, but I think the most important thing is just to have a routine that sort of signals to yourself behaviorally that you're getting ready to turn things off.
Okay, excellent, good to know. We talked a little bit about your devices and electronics. So this kind of goes along with that, particularly since we've been dealing with COVID here recently. Socialization might look like Zoom sessions like this. What are your thoughts on, how we can continue to socialize, and would you consider Zoom or using electronics as a medium to stay connected as a way to do so?
Yes, absolutely. So I think right now, Zoom and other electronic connectivity is a way to maintain socialization. Obviously, the screen time thing we just talked about with sleep, maybe try to sign off an hour or so before you go to bed. But this is, I think as we adjust to this, Zoom, it's not quite as good as in person, but certainly it has advantages, right? Because it's less reliant on your ability to be mobile and to have transportation. You can connect with people all around the country, or frankly, all around the world, simply by logging in to your Zoom account, for instance. And so if you have family members in different parts of the country, you can get more than one person on at the same time, as just like this. And so I think that is definitely worth continuing to do, even once the pandemic is over.
Okay, that's helpful to know. You referred to wellness treatments not being reimbursed by insurance. What might be some examples?
Well, so a lot of these things that we're talking about, depending on the type of insurance you have, finding certain types of therapists that are, maybe involved in mental health, like cognitive behavioral therapy, or sometimes people like other types of interpersonal therapies, they might not be supported. And certainly, yoga, for instance, or certain types of exercise classes may or may not be, supported. And so that's one of the problems.
Yeah, and that you would think that we consider that as a way to prevent, or to continue our good health. And I don't know, we'll see what happens there. So let's continue discussion around exercise. How much exercise is recommended? And what's your opinion on programs such as rock steady boxing, Tai Chi that have been recommended for people with Parkinson's?
Yeah, so those are great questions. And so the way to think about this maybe is, how do we dose exercise? What's the amount, the intensity, the variables that make it the most effective? And so one of the things that we know is that at least 150 minutes per week, okay, however you divide that up, is what's recommended by the American College of Sports Medicine for everyone, whether you have Parkinson's or not. So I think as a minimum threshold, you should aim to get 150 minutes of moderately vigorous exercise. So that brings us to the next variable, is intensity. You really do have to have a fair degree of intensity for exercise to be valuable. So in the trials that look at exercise as medicine in diseases like Parkinson's and Alzheimer's, the intensity has to be high enough to make you breathe hard and sweat. And so or at least the intensity that gives maximal benefit. And so at least some of that time should be at a relatively high intensity. And so, programs like rock steady boxing or any sort of group exercise has an advantage, because one, it's usually proctored by someone. There's usually a trainer or a physical therapist who is helping to keep the intensity up. And in social things like rock steady boxing, your peers are cheering you along to keep that intensity up. The other thing that doing exercise socially brings is that there's an accountability. So if Jim and Bob and Sally are going to be there on Thursday and you don't show up, you're going to hear about it. And so we found it also increases compliance with the treatment. And so again, I love the idea of anything that's done in a group, because if you have individual exercises and you're good about doing them, that's great. But if you have a little bit of trouble with motivation and or intensity, doing group exercise really adds that element, I think.
And maybe you could talk a little bit more about intensity and how we define that. How will we know that we are working at the appropriate intense level?
Well, that's sort of one of the things that I think has to be investigated a bit more. But what I can tell you is that, at higher levels of intensity, the blood's moving more rapidly, your body is activated in a way that it generates more free radical scavengers, which some of the literature posits as the potential mechanism for disease beneficial exercise. And so, doing a stationary bike to the point where you're sweating and breathing hard is one of the things that we think might make the difference between somewhat helpful exercise and optimally helpful exercise. And so exactly what that level of intensity is not known. So we don't know if it would be measured by oxygen exchange or heart rate or whatnot, but we do know, and this is, not just in Parkinson's, but in exercise science in general, that if you can safely sustain it, the higher intensity is generally more helpful. The exact mechanism as to why is not clear at this time.
Very interesting. Thank you. So let's go on the other end of the spectrum. What are your thoughts about meditation, and can it be beneficial for PD?
Yeah, so this is, there's different types of meditation. And so I think one of the things that's really interesting is that if you look at cognitive behavioral therapy, which is the best researched, and has the most scientific evidence type of talk therapy for mental health conditions, and then you look at meditation, they fundamentally do some similar things. So the thing that cognitive behavioral therapy does is it separates your emotions and thoughts from your behaviors, and especially your maladaptive behaviors. In meditation, you learn to sort of let things that would bother you pass by. You sort of identify them, you acknowledge them, in some cases you accept them, and it's in a way doing the same thing. It's separating the things that sort of act negatively upon us from the actions that will ultimately make us successful. And so, meditation is, to me, like the calisthenics for the brain. We have exercises that we do for the body. I think meditation is one of the fundamental calisthenics or foundational exercises for the brain. And so anyone with interest, I recommend that you take a look at some of the meditation studios near you. They're hard to find sometimes. They're often paired with things like yoga, and there's some good books too out there, so that you can read and then just start the mindfulness part of meditation. Mindfulness is just, I think, part of meditation, and then depending on how involved you want to get, you can seek out mentorship. So it's a little more involved, but I think unlike cognitive behavioral therapy, where it's limited by a number of modules that are administered, once you learn the practice of meditation, it can be self-sustaining. So I do think for those who are interested, it isn't like something from the 60s and 70s that's just soft, and it's not necessarily culturally or religiously bound to one discipline. And so if you have an interest, it's certainly something to seek out.
Okay, calisthenics for the mind. I like that. A question now about overactive bladder, OAB. Can this be a symptom of PD?
Yeah, so it turns out that Parkinson's disease for many affects the autonomic nervous system, both the parasympathetic and sympathetic branches of the autonomic nervous system. And the detrusor muscle, which is the muscle that surrounds the bladder, is innervated by that autonomic nervous system. And so one of the most common changes in urinary function that we see in Parkinson's is what we call urge incontinence. And so that sometimes you can call that overactive bladder. It's this feeling that you have to go, and you have to go urgently. And the more you rush, sometimes you don't make it. And so that is something that can come with the Parkinson's. And there are medications that can help a little bit. And so certainly, again, starting with your neurologist and then potentially a referral to a urologist is well worthwhile. But again, this is one of those things that I think also makes people a little more avoidant of social situations. So it's definitely a barrier that I think should be addressed so that you don't have a lower quality of life due to avoidance.
Mm-hmm. So we have just a couple more minutes to go. I just want to let all of those attending today know that if you have any other questions, to put them in a chat, and any that we don't get to today, we're happy to forward on to Dr. Pontone. But I did see a question here specifically about fatigue. We talked about exercise, and we talked about meditation. And of course, there's always this issue of fatigue and getting going and having the motivation. So risk factors for Parkinson's. more men than women? And is there a Parkinson's personality?
That's a great question. So it is conspicuous that there's more men than women in Parkinson's, because many other neurological diseases like multiple sclerosis are more, in Alzheimer's, are more women than men. And so one idea is that it's very probable that a fair amount of Parkinson's is environmentally determined, meaning that someone was exposed to something and then developed Parkinson's. And at least traditionally, men have been in occupations and involved in the armed forces here, and therefore some of the known exposures might be occurring in men more than women. So that's one idea as to why it might be occurring more in men than women. And then in terms of a Parkinson's personality, there is certainly a lot of scientific papers written about that. And there's one idea that because the dopamine loss that ultimately causes the movement symptoms is occurring maybe for a decade or more before you actually start to show the movement symptoms, that might play a role in altering your personality. So one of the things that I can tell you both anecdotally and from some support from the literature is that on average, the people I work with who have Parkinson's are less likely to have substance abuse addictions. And so in order to sustain an addiction, even things like smoking, addiction to nicotine, you have to have dopamine to reinforce that addiction. And as you're losing dopamine, there's an idea that maybe that's why there's less substance abuse in general in people who ultimately develop Parkinson's disease. And that's on average across the population. That's not to say that one individual would, but I also find that people with Parkinson's are good at delaying gratification. And so, they're, I think, less likely to sort of impulsively do things, prior to the disease. And so that sort of personality profile fits, and also high neuroticism. So the tendency to sort of experience negative emotions tends to be a little higher in Parkinson's as well.
Wow. Well, this has been a fascinating discussion, and thank you for your presentation today. We have a few more breakout sessions after this. I want to remind everyone that we're going to head back to the original website, which is meyerberg.org/LWP. I will put it in the chat, and we will continue our day with lots more to come. Thank you, Dr. Pontone. I wish you a wonderful rest of the weekend, and please do stay in touch. We'll forward any additional questions that may come up after today's session. Okay, thank you so much.
This completes our current session. This meeting will end in 1 minute. Please proceed to meyerberg.org/LWP and click Join Session of the next session. Thank you.